Hypertrophic cardiomyopathy. Dr.Vinod.G.V. Definition. HCM is a disease state characterized by unexplained LV hypertrophy associated with non-dilated ventricular chambers in the absence of another cardiac or systemic disease that itself would be capable of producing the magnitude of hypertrophy evident in given patient. HCM is a common genetic cardiovascular disease prevalence estimated to be 1 to 500. Genetics. Caused by autosomal dominant mutations in genes encoding protein components of the sarcomere and its constituent myofilament elements. 1,400 mutations identified among at least 8 genes. HCM genes and their frequencies. Chromosome. Frequency percent. Beta MHC. 14q1. 35 to 50. MyPC. 11q11. 15 to 20. Cardiac troponin T. 1q3. Alpha tropomyosin. 15q2. Less than 5. Cardiac troponin I. 19q13. Less than 1. MLC1. 3p. MLC2. 12q. Alpha cardiac actin. 15q11. Titin. 2q31. Unknown. 7q3. Beta MHC mutations clinical presentation apparent by late adolescence and develop substantial hypertrophy and more severe diseases. MyBPC mutations can have delayed clinical presentation until age 50 or older. Less severe symptoms. 1 essential myosin light chain mutation associated with mid-cavitary hypertrophy. CTNT mutations modest hypertrophy, increased risk of sudden death. CDNI mutations greater predisposition of apical hypertrophy. Alpha tropomyosin relatively good survival. Variable degree of hypertrophy. Insights from genotype/phenotype studies. Autosomal dominant disease affects males and females equally. Only 50% of the offspring of affected individuals will be at risk of inheriting the gene and developing the disease. The offspring of unaffected family members carry no risk of inheriting the gene and developing the disease. In any one family with FHCM, all affected members have the same mutation. The onset of clinical manifestations is usually delayed until adolescence or early adulthood. Clinical features of the phenotype are not predictive of sudden death. In certain genes there is a high correlation between the extent of ventricular hypertrophy and the incidence of sudden death. Certain mutations are highly predictive of sudden death. Morphology: asymmetric hypertrophy with small left ventricular cavity. Diffuse hypertrophy of septum and anterolateral free wall 70 to 75%. Basal septal hypertrophy 10 to 15%. Concentric hypertrophy 5%. Apical hypertrophy less than 5%. Hypertrophy of lateral wall 1 to 2%. Mitral valve apparatus. Twice the normal size due to elongation of both leaflets or segmental enlargement of only anterior leaflet or mid-portion of posterior leaflet. Congenital endonomatous anterolateral papillary muscle insertion into the anterior leaflet without interposition of chordae tendineae and produce muscular mid-cavity outflow obstruction, histopathology. Bizarre arrangement of muscle fiber bundles. Myocardial disarray consists short runs of severely hypertrophied fibers interrupted by connective tissue. Myocardial fibrosis with degenerating muscle fibers. Whirling of muscle fibers. Volume of interstitial collagen increases. Abnormal intramural coronary arteries with thickened wall and narrow lumen near to areas of replacement fibrosis. Microvascular disease: silent myocardial ischemia, myocyte death, replacement fibrosis often transmural. Pathophysiology of Vault obstruction. Produced by SAM of mitral valve and mid-systolic ventricular septal contact. SAM is abrupt anterior motion of the mitral valve in which elongated leaflets move toward the septum with a sharp angled 90-degree bend and generated largely by a drag effect, hydrodynamic pushing force of flow directly on the leaflets. In the classic form of obstructive HCM, the obstruction will occur at the most basal portion of the septum as it projects into the left ventricular outflow tract. The obstruction may also extend into the left ventricle from SAM of the chordal apparatus. Patients with midventricular obstruction hypertrophied papillary muscle abuts against the ventricular septum. Most patients will have SAM of the anterior leaflet, but this may also occur with the posterior leaflet. The exact site of the obstruction may be determined by visualizing the region of the SAM septal contact. Obstruction is dynamic, varying with loading conditions and contractility of LV. Increase in contractility. VPC. Dobutamine, isoproterenol. Exercise. Decrease in afterload/volume. Valsalva maneuver. Nitroglycerine/amyl nitrite inhalation. Blood loss. Dehydration. Definitions of dynamic left ventricular outflow tract obstruction. Hemodynamic state. Conditions. Outflow gradient. Basal obstruction. Rest. 30 mm of mercury. Non-obstructive. Less than 30 mm of mercury. Physiologically provoked. Label obstruction. Diastolic dysfunction. Impaired relaxation, filling and increased ventricular stiffness. Contributing to the symptoms. Rapid filling phase is prolonged. Decreased rate and volume of filling. Compensatory increase in atrial filling. Decreased compliance is due to hypertrophy, replacement scarring, interstitial fibrosis and disorganized cellular architecture. Microvascular dysfunction. Myocardial ischemia. Myocardial ischemia is unrelated to epicardial coronary artery disease. Supply-demand mismatch due to hypertrophy. Abnormally small and partially obliterated intramural coronary arteries. Ischemia causes myocardial scarring and remodeling and replacement fibrosis, which is a determinant of progressive heart failure and substrate for arrhythmia. Mitral regurgitation, common in patients with vault obstruction. Secondary to distortion of mitral valve apparatus from SAM. The jet of Mr. is directed laterally and posteriorly and predominantly during late and mid-systole. Severity proportional to vault obstruction. Clinical features. Symptoms. Majority are asymptomatic. Dyspnea occurs 90% of symptomatic patients. Syncope and pre-syncope in 20 and 50% respectively due to either hemodynamic or rhythm abnormality. Angina -70 to 80%. Small artery narrowing. Intramural compression of small arteries from myocardial hypertrophy. Abnormal diastolic filling. Oxygen supply-demand mismatch. Abnormal coronary flow reserve. Physical examination. Classic findings applied to patients with vault obstruction. Carotid pulse is brisk with spike and dome pattern with a rapid rise, percussion wave, followed by a mid-systolic drop and turn followed by a secondary wave, tidal wave. Apical impulse double or triple. Second heart sound paradoxical split 20%. Fourth heart sound is present. Murmur, crescendo decrescendo at left sternal border. Radiates to base as well as apex. Seldom radiates to carotid arteries. Dynamic auscultation. Maneuvers that decrease preload will increase the dynamic gradient and increase intensity of murmur. E.G. Standing and strain phase of Valsalva. ECG abnormal in 95% of HCM patients. LVH seen in 70 to 80% patients. Abnormal Q waves simulating myocardial infarction due to disturbance of activation of ventricular septum. Apical HCM diffuse symmetric T wave inversion across precordium. Atrial fibrillation: 25 to 30% of older patients. Cardiac catheterization. Pullback pressure tracing. Systolic gradient between the apex and base. The small left ventricular cavity: hyperdynamic systolic function. Catheter entrapment may occur, resulting in a falsely increased left ventricular systolic pressure, ideally assessed by a simultaneous left ventricular inflow and left ventricular outflow, or aortic, pressure. Inflow position avoids the problem of catheter entrapment and is best obtained by a transeptal approach. Brockenbrough phenomenon. Useful for latent obstruction. After a premature contraction. Increase in the contractility of the ventricle. Marked increase in the degree of dynamic obstruction. Increase in gradient and a decrease in the aortic pulse pressure after the pause. Fixed obstruction, increase in gradient from the increase in stroke volume, increase in aortic pulse pressure. Left ventriculography. Small left ventricular cavity size with hypertrophied papillary muscles. Hyperdynamic systolic function, complete obliteration of the mid and apical cavity in systole. Apical HCM, fixed obliteration of the apex by the hypertrophied muscle, spade-like configuration. An apical akinetic dyskinetic pouch with aneurysm formation. Midventricular obstruction. An apical akinetic dyskinetic pouch with aneurysm formation. Stress testing. Important adverse prognostic factors: decrease in blood pressure, appearance of ventricular arrhythmias. Exercise is the most physiologic form of provocation to attempt to detect latent left obstruction. CMR more accurate than echo can detect 6% more hypertrophy. Accurate measurement of thickness should be done in poor echo window. Discrepancy between clinical findings, ECG, echo. CMR, poor prognostic factors. Markedly elevated LV mass index, men greater than 91 grams/m2, women greater than 69 grams/m2, sensitive 100%. Maximal wall thickness of more than 30 mm, specific, 91%, for cardiac deaths. Type 1: anterior segment of septum 10%. Type 2: both anterior and posterior segment 20%. Type 3: septum and anterolateral free wall 52%. Type 4: other regions including apical HCM, 18%. Right ventricular, RV, hypertrophy. Myocardial edema by T2 weighted imaging. LG has been associated fault with ventricular arrhythmias, progressive ventricular dilation, burned out HCM. 3% manifest the end-stage systolic dysfunction, ejection fraction less than 50%. Progressive heart failure, often associated with AF. Patterns of LV remodeling, wall thinning and cavity dilation. Diffuse transmural scarring, the consequence of small vessel-mediated myocardial ischemia. Progression to refractory heart failure or sudden death is frequent, 10%/year. The most reliable risk marker for evolution to the end stage is a family history of the end stage. 2D echo. Diffuse hypertrophy of the ventricular septum and anterolateral free wall, 70% to 75%. Basal septal hypertrophy, 10% to 15%. Concentric hypertrophy, 5%. Apical hypertrophy, less than 5%. Hypertrophy of the lateral wall, 1% to 2%. Young population diffuse hypertrophy of the entire septum with a convex septal contour. Older population appearance of a sigmoid septum, hypertrophy is localized to the basal and mid-septum. Doppler echocardiography. Dynamic levote obstruction. A high-velocity dagger-shaped signal. In low outflow tract velocities less than 3 meters per second. Provocation with the Valsalva maneuver, inhalation of amyl nitrite or exercise to determine a labile or latent obstruction. Presence and severity of mitral regurgitation. If mitral regurgitation is secondary to SAM, the color jet directed laterally and posteriorly. Regurgitation will predominate in mid to late systole. Dynamic levote obstruction, DLEs. Elderly patients with hypertension treated with vasodilators, diuretics or digoxin. Postoperative period intravascular volume depletion and inotropic use. As after AVR. Mitral valve prolapse after MVR. Acute anterior apical ME. Some patients with apical ballooning, DTI of the mitral annular motion, which is abnormal in HCM patients despite normal or supernormal ejection fraction. Abnormally low annular velocities, useful in detecting subclinical disease. Useful in distinguishing HCM from athlete's heart. Preserved or enhanced annular velocities. Athlete's heart versus hypertrophic cardiomyopathy. HCM can be asymmetric. Wall thickness, greater than 15 mm. LA, greater than 40 mm. Levet frown 45 mm. Diastolic function, always abnormal. Athletic heart. Concentric and regresses. Less than 15 mm. Less than 40 mm. Greater than 45 mm. Normal. Management. Sudden cardiac death. Most commonly in adolescents and young adults less than 30 to 35 years of age. Often the initial clinical manifestation of HCM, commonly in asymptomatic individuals. Events are arrhythmia-based primary ventricular tachycardia and ventricular fibrillation. High-risk secondary prevention prior cardiac arrest. Sustained ventricular tachycardia. Primary prevention risk markers. 1. Family history of one or more premature HCM-related deaths, particularly if sudden and multiple. 2. Unexplained syncope, especially if recent and in the young. 3. Hypotensive or attenuated blood pressure response to exercise. 4. Multiple, repetitive or prolonged NSVT on serial ambulatory, Holter, ECG. 5. Massive LV hypertrophy, wall thickness greater than or equal to 30 m, potential arbitrators. Contrast enhanced CMR delayed enhancement. LV apical aneurysms associated with regional myocardial scarring and ventricular tachyarrhythmias. The end-stage phase. Percutaneous alcohol septal ablation with transmural myocardial infarction. Risk stratification. Family screening strategy. Age less than 12 years. Optional unless family history of premature death from HCM, age 12 to 18 to 21 years. Every 12 to 18 mo. Age greater than 18 to 21 years. An onset of symptoms or at least every 5 years. More frequent intervals are appropriate in families with late onset HCM. Genotype positive/phenotype negative patients. Class 1 serial ECG, TTE, and clinical assessment at periodic intervals 12 to 18 months in children and adolescents, every 5 years in adults, based on the patient's age and change in clinical status. Medical therapy. Initial therapeutic approach to relieving symptoms with obstructive HCM. Beta-adrenergic blocking agents are the initial drug of choice. Beta blockers. Advantages of beta blockers include 1. Decreased heart rate response to exercise. 2. Decreased outflow tract gradient with exercise. 3. Relief of angina by a decrease in myocardial oxygen demand. 4. Improvement in diastolic filling. Dosage should be titrated to symptom relief or to obtain a resting heart rate of less than 60 beats per minute. May require up to 400 mg equivalent of metoprolol. No proven reduction in the incidence of SCD with blockade. Calcium channel blockers. Specifically verapamil and diltiazem. Decrease inotropy and chronotropy. Also improve abnormal diastolic relaxation by preventing calcium influx. Verapamil used most frequently due to its minimal effect on afterload. In contrast to beta-blocking drugs, an improvement in diastolic filling occurred with verapamil. CCBs may improve angina to a greater degree than beta-blockers. Verapamil sustains symptomatic improvement in less than 50% of patients. Resting heart rate of 60 beats per minute and may require up to 480 mg/d. Hemodynamic deterioration with CCBs due to a lowering of the afterload, particularly in the presence of severe outflow tract gradients and high diastolic filling pressures. Death from pulmonary edema has been reported after therapy with verapamil. Diltiazem. More vasodilating properties. Dihydropyridines will increase the severity of the outflow tract by reducing afterload. Disulfiramide. The negative inotropic effect will decrease the gradient and improve symptoms. Concomitant beta blockade to prevent rapid atrioventricular node conduction. Dosage 300 to 600 mg/d. Corrected QE interval to be monitored at the initiation. Standard practice is to start beta blocker as the initial therapy. Gradually increase to optimal dosages. If patients cannot tolerate beta blockers due to adverse effects of CCB, verapamil should then be started. Severe outflow tract obstruction and symptoms, CCBs should be started under monitored conditions in the hospital. No data to show that the combination of two drugs is better than one drug alone. Disulfiramide may be added to either the beta blocker or verapamil if symptoms persist. Septal myectomy, Moro procedure. Gold standard therapy for patients with obstruction and severe drug refractory symptoms, eligible patients for myectomy. Clinical. Severe dyspnea or chest pain, NYHA classes 3 or 4, despite optimal medical therapy. Hemodynamic. Dynamic vote gradient at rest or with physiologic provocation 50 mm Hg associated with septal hypertrophy and SEM of the mitral valve. Anatomic. Targeted anterior septal thickness sufficient to perform the procedure safely and effectively. Transaortic resection of 5 to 15 grams muscle from the proximal to mid-septal region. Enlarges the vote and significantly decreases or totally abolishes vote obstruction. Mitral regurgitation secondary to SEM of the mitral valve also disappears. Septal ablation. NYHA class 3-4 symptoms despite maximal medical therapy. Septal thickness greater than 18 mm. Subaortic gradient greater than 50 mm of mercury due to mitral septal contact. Absence of papillary muscle or mitral valve anomalies. Absence of significant coronary arterial disease. Compatible septal perforator branch arterial anatomy. Relative contraindications to surgical myectomy. Age, comorbidity. Initial results reported successful short-term outcomes. The outflow tract gradient is reduced from a mean of 60 to 70 mm Hg often to less than 20 mm Hg. 75% to 80% of patients are improved from the symptomatic standpoint. Complications. Complete heart block. 10 to 20% require permanent pacemaker implantation. More likely to experience if LVBB was present prior to the ablation procedure. Other complications. Coronary dissections. Large myocardial infarctions from leakage of the alcohol. Ventricular septal defects. Myocardial perforations. Conclusion. SID seem to show promise in treatment of HOCM owing to similar mortality rates as well as functional status compared with SM. The caveat is increased conduction abnormalities and a higher post-intervention LVOT. The choice of treatment strategy should be made after a thorough discussion of the procedures with the individual patient. J.M. Cole Cardiol 2010 55 to 823 to 34. DDD pacing. Objective measurements of exercise capacity did not differ significantly. Overall decrease in outflow tract gradient, 25 to 40% of baseline. Role of dual chamber pacing, patients at high risk for other therapeutic modalities. Candidates for dual chamber pacing. Significant bradycardia in which pacing may allow an increased dosage of medication. Patients who need ICD as a primary treatment. Indications for ICD. Thank you. 1. False statement about HCM mutations A. 1. False statement about HCM mutations A. Beta MHC mutations presence in adolescence B. CTNT mutations associated with sudden death C. MyBPC mutation can have delayed clinical presentation D. CTNT mutation is associated with more apical hypertrophy. 2. All the following increases LVOT obstruction in HOCM except A. 2. All the following increases LVOT obstruction in HOCM except A. Valsalbumin or B. Amyl nitrite C. Dehydration D. Disulfiramide. 3. All true about beta blocker therapy in HCM except A. 3. All true about beta blocker therapy in HCM except A. Decreased outflow tract gradient with exercise B. Relief of angina by a decrease in myocardial oxygen demand C. Improvement in diastolic filling D. Prevents the incidence of SCD. 4. All are risk factors for SCD except A. Wall thickness greater than or equal to 30 m. B. NSVT on holder. C. Hypotensive response with exercise test. D. Multiple VPCs. 5. All are indications of alcohol septal ablation except A. 5. All are indications of alcohol septal ablation except A. NIHA class 3-4 symptoms despite maximal medical therapy B. Septal thickness greater than 18 mm C. Subaortic gradient greater than 30 mm of mercury D. Absence of papillary muscle or mitral valve anomalies. 6. True regarding alcohol septal ablation except A. 6. True regarding alcohol septal ablation except A. 10 ml of absolute alcohol is injected B. Immediate reduction of LVOT gradient C. Increased incidence of complete heart block D. Predisposes to SCD. 7. All are true regarding medical management of HCM except A. 7. All are true regarding medical management of HCM except A. Beta blockers are the initial drug of choice B. CCBS cause better angina control than beta blockers C. Dual TSM can precipitate acute pulmonary edema D. Combination of beta blockers and CCBS more effective than single drug. 8. Echo features of HCM all except A. Septal hypertrophy greater than 15 mm B. 8. Echo features of HCM all except A. Septal hypertrophy greater than 15 mm B. Dagger-shaped Doppler spectrum C. SEM of anterior mitral valve. D. Increased mitral annular velocity on DTI. 9. All are true regarding athlete's heart except A. 9. All are true regarding athlete's heart except A. Wall thickness less than 15 mm B. LVET greater than 45 mm C. Diastolic function is normal D. LVH does not regress on deconditioning. 10. All are potential arbitrators for SCD except A. In stage phase B. 10. All are potential arbitrators for SCD except A. End stage phase B. LV apical aneurysm C. CMR late gadolinium enhancement D. Unexplained syncope of recent onset. References: Braunwald's Heart Disease 9th edition, Hurst 13th edition. ACC AHA 2011 Guidelines. Topol Interventional Cardiology 5th. Feigenbaum's Echocardiography 7th. Bonita Anderson Echocardiography. Nahan 2004 March 25. Rickey, Nishimura.